Please click the like and subscribe buttons so that you can receive more of MAP's clinical pearls and technique videos.
Hey guys, Travis Stoner with Maitland Australian Physiotherapy Seminars. Today I'd like to talk with you a little bit about shoulder quadrant assessment. A lot of us, when assessing maybe cervical or shoulder pain or in dysfunction, we'll go through our normal cardinal planes of motion, flexion, abduction, but that isn't how we tend to move in normal life. Even as I'm moving my arm around while talking with you, you can see that I'm doing a lot of rotation and diagonal movements all through my glenohumeral joint. Assessing the shoulder quadrant is an excellent way of seeing exactly how the patient's shoulder is moving through a more functional range. And so this isn't necessarily something that you can document, but it's something for you to put in the back of your mind, make a movement diagram on, something along those lines to help you really assess where in the range a patient might be having the most amount of problems. So, step one for doing a shoulder quadrant is you'll want to take the hand that is closest to the patient, get it up underneath of their scapula, and then give a very light hold. You don't want to lock it down, you just kind of want to hold it there. So I'm going to slip my right arm right underneath of Carly's shoulder blade. You can see my fingers right here, just kind of lightly holding into that supraspinatus fossa. Next, my left hand is going to very lightly cup right around the elbow. I am then going to take her into a little bit of internal rotation, a little bit of abduction and extension, and put her in what we call the shoulder lock. So she's stuck right here. She's not moving. So if I start pushing on this, how's that feel?
Tight.
Tight. It ain't going anywhere. So that's your starting position. You do not then want to force their arm through the rest of this motion. You want to let it guide. What you will notice is coming out of the lock, you'll start to come up and around, and when you get to the apex, the elbow will want to come back towards you a little bit. That little space right in there, we kind of refer to as the cave. You'll then come out of the cave and on top of the mountain, and then normally that will glide right back down towards the patient's ear. So just so you can see this in real time, you get the shoulder lock, and then you're going to lightly take the patient through a range all the way up. What you'll notice in a lot of patients with shoulder dysfunction is as you're taking them through, they will come up the hill at a certain level in this quadrant, and then they'll never come back down. Or they'll stay up for a prolonged period of time through mid-range, and then they'll drop down there near the end. Or they'll come up through and it'll be a shoulder quadrant, and then right near the end, they'll start pulling way back up. It gives you a better idea as a form of assessment to where you might want to guide your treatment and different treatment options that you can do when working with patients with shoulder dysfunction.